From Microbe TV, this is TWiP, This Week in Parasitism, episode 222, recorded on October 19th, 2023. I'm Vincent Racaniello, and joining me today here in Chicago, Illinois, Dixon Despommier.
Hello, Vincent, and everybody else. It's a pleasure to be here.
I will talk about why we're in Chicago in a moment, but let's introduce everyone else here in Chicago. Daniel Griffin.
Hello, everyone.
Here in Chicago, Christina Naula.
Hello, everybody. It's good to see you all in person in Chicago.
We have a special guest who contributed our clinical case. She is from the University of California, San Francisco, Natasha Spottiswoode. Welcome to TWiP.
Thank you so much, Vincent and Daniel and Dixon and Christina. It is an absolute delight to be here with you today.
We're going to talk all about you and our interesting overlaps in a bit. But first, Dixon, why are we in Chicago?
Well, Vincent, it's a very simple answer for a very simple question. The answer is we're at the American Society for Tropical Medicine and Hygeine annual meeting, which last year was held in Seattle, and this year it's being held in Chicago.
And what is this meeting about?
Well, the ASTM&H, as we all refer to it, because it's a big mouthful of letters and words, is dedicated to the diseases which are primarily found throughout the tropics, and also the ability of hygiene, sanitation in that sense, to correct a lot of these problems. And all of the world meets at this meeting once a year to discuss the latest updates.
You've been to a number of these meetings, haven't you?
I've actually served on the council for this society for about 8 years. I've been a member of it since I was a graduate student at the University of Notre Dame, and I haven't stopped my membership. I love the people that come to this meeting. They come from all over the world. We accept everybody who's interested in saving humanity from the plagues that lurk in the shadows of the tropics and subtropics.
Daniel, I think it's interesting that hygiene is still part of the name, right?
I know. I hope people recognize that and continue to appreciate the importance of hygiene. I should recount my first attendance at one of the annual meetings. I had the, shall I call it, pleasure of driving down with Dixon in his Prius and being recounted many, many stories.
I'm sure. Christina, have you been to many of these meetings?
I went to my first ASTM&H last year in Seattle, so had a really good time.
Okay. How about you, Natasha? Have you been?
Yes, I've been to ASTM&H once before, which I think was 2011, when I was a graduate student at the National Institutes of Health and attended in Washington, D.C. And I thought, this is really cool. I hope I get to come back. And it only took about a decade and quite a lot of medical training and residency and fellowship, but I've eventually made it home to ASTM&H.
Well, we were here last year, yes. We did a TWiP without you, unfortunately, Dixon. But this year you're here, so here we go. And this is TWiP, This Week in Parasitism. So it means we have a clinical case, Daniel.
We do. And for those of you tuning in for the first time, those of you tuning back in, Natasha is going to remind us of our mystery case.
Fabulous. So I'll just dive right in. This is the case of a man in his 50s with no remarkable prior medical history who received care at a hospital in Northern California in the USA after he experienced a generalized seizure. At that time, MRI, or magnetic resonance imaging, demonstrated a solitary left temporal lobe T2 hyperintense with gadolinium ring enhancement and surrounding edema. He received treatment with dexamethasone and levetiracetam and was transferred to an academic medical center. The exam at that point by the neurology consultants noted disorientation, inattention, moderate aphasia, or difficulty communicating, and mild right hemiparesis. Cerebrospinal fluid, or CSF, testing showed increased nucleated cells up to 80 per microliter, which were 60% lymphocytes, 17% neutrophils, and 23% monocytes, a protein concentration of 38 mg per deciliter, and a glucose concentration of 100 milligrams per deciliter. They proceeded to do a brain biopsy from the left temporal lobe lesion with cultures from the brain biopsy sample, but these cultures did not grow bacteria, fungi, or mycobacteria. We then performed metagenomic next-gen sequencing, or MNGS, on a CSF sample and sent brain biopsy samples for broad-range PCR amplicon sequencing, or UPCR, for bacteria, fungi, Mycobacterium tuberculosis, and non-tuberculous mycobacteria. Pathology at that point showed well-formed granulomata with acute inflammation. Re-review of neuropathology by some very clever neuropathologists then raised concerns for certain round infectious forms, about 50 micromolars in size, with some surrounding clearing and a dark area within these forms.
All right, we have a bunch of case guesses. Daniel, could you take that first one?
All right, I will start with the first one. Rafid writes, greetings from rural Quebec. Thank you again for an excellent podcast and for volunteering your time. When I first listened to this case, the first diagnosis that came to my mind in a man with a ring-enhancing brain lesion is cerebral toxoplasmosis. However, I presume that he had a negative HIV test, or else a brain biopsy would not have been performed. Also, if I remember correctly, the HIV patients that I took care of on the hospital wards in the early 90s, cerebral toxo was a late and not an initial presentation of HIV, although the fog of 30 years may have affected my memory. Thus, it would be an unusual presentation in a previously healthy person. The histology and size of the parasites does not seem to be in keeping with the Google description of cerebral toxo as well. Therefore, although very rare, I think this patient may have cerebral granulomatous amoebic encephalitis. Balamuthia amoeba may infect healthy people and explain the histological findings of granulomatous inflammation and 50-micron organisms. Last week, I attended the Canadian Society of Internal Medicine conference where a resident presented a case of a 70-year-old woman with a similar lesion and no risk factors without any unusual exposure who lived in Montreal who had similar biopsy findings with 50-micron amoeba and granulomas on her brain biopsy, who unfortunately succumbed to her illness. Therefore, even though I am not sure what the diagnosis is, I think the karma of seeing a similar case at the conference is too much of a coincidence. Therefore, amoebic granulomatous encephalitis is my final answer.
Natasha, could you take the next one?
Of course. Elise writes, Dear TWiP Collective, I am back after another unforgivable hiatus. I hope this finds all of you well, and I was so happy to write this just before your live recording at the ASTMH meeting in Chicago. The weather in Lower Manhattan is pretty autumnal, 62 degrees Fahrenheit or 17 Celsius, and primarily sunny. I seem to have timed my return to a particularly worrisome case study, and I also inadvertently cheated on it. While researching, I believe I bumbled right into a paper that was written about this poor patient's case, so it was not too much for me to guess that this gentleman is suffering from Balamuthia mandrillaris. I am supposing that the amoeba was named because it was first identified in a mandrill that succumbed to an infection in San Diego. This is a really devastating, and thankfully rare, amoebic infection. Although the amoeba in question can be found all around the world, it seems to somewhat prefer warmer climes, unlike New York. While I can take no credit for clever deduction, I do wonder about this infection. I know that it is usually fatal, and that this gentleman was rescued by off-brand use of nitroxyline. Were other amoebicidal drugs considered? How long did it take for the FDA to give permission for its use on this patient? Have subsequent patients dealing with this amoeba been treated the same way? As always, thank you so much for your work, and many, many best wishes, Elise.
Christina.
Paul writes, Dear TWiPers, I'm writing you out of the lovely heat of 32°C and 80% humidity of the Gambia. Thank you very much for your very entertaining episodes. I'm really enjoying learning in this way. I thought I might give it a try to have a guess for your 50-year-old male with a generalized seizure. We don't have any travel history or information about sexual activity. Neurological symptoms may be explained due to the temporal lesions identified on MRI. CSF and brain biopsy hopefully ruled out malignancy, bacterial and fungal infections, and as this is TWiP, we are looking for something more fancy. Glucose and protein levels in normal range make crypto and TB unlikely. My guess would be an infection with toxoplasma, which would explain the ring-enhanced lesion and can be easily transmitted from our beloved pets. Neurocysticercosis, as one of the most common causes of epilepsy in adults worldwide, might also be possible. Serological testing, an HIV test, and a further history of contact to pigs or pets might be helpful to find the right diagnosis. Best regards, Paul.
Dixon.
Thank you. Byron writes, Dear TWiP hosts, good morning from Illinois, which is where we are, where fall is undoubtedly approaching. Weather outside is 67 and cloudy. I cannot help but kicking myself after hearing last week's case study. Such good odds to win the textbook. I shall keep trying. My research had me focused on two possible outcomes: neurotoxoplasmosis, caused by Toxoplasma gondii, and amoebic meningoencephalitis, caused by free-living amoebas. They both induce ring-enhancing lesions in the brain, but for toxoplasmosis, usually in immunocompromised patients. There is no mention of such medical history in this case, so my final guess is amoebic meningoencephalitis caused by free-living amoeba. Thank you for all you do, and please keep the cases coming. Byron.
All right, this one is from last episode's guests, Michelle and Alexander. Right. Dear TWiP professors, 5 unicellular parasites that invade the central nervous system come to mind when examining this case. Number 1, Toxoplasma does not typically cause granulomatous disease. Number 2, Naegleria, a parasitic infection caused by Naegleria fowleri, which is an amoeba that leads to primary amoebic meningoencephalitis, PAM, but does not cause focal granulomas. Usually this disease leads to death long before all bacterial cultures from biopsy come back negative. Naegleria can also be detected in cerebrospinal fluid, but this is not routinely examined. Number 3, Acanthamoeba is a free-living amoeba with typical uninuclear morphology, although it typically is much smaller than 50 microns, and it is more likely to be found in immunocompromised patients. Infected individuals can develop granulomatous amoebic encephalitis, GAE. Number 4, Balamuthia mandrillaris, named after the animal it was first found in. This parasite causes disease in immunocompetent patients. The trophozoite ranges from 15 to 60 microns in size and has 1 to 3 nuclei, while Acanthamoeba has only 1. This disease can also lead to granulomatous amoebic encephalitis, which is oftentimes fatal, although there are now multiple reports of patients surviving this disease. An indirect immunofluorescence assay, immunohistochemistry, and PCR may be helpful tools in diagnosing Balamuthia infection. Drugs that have shown promising effects include flucytosine, pentamidine, fluconazole, azithromycin, and clarithromycin. How am I doing on the pronunciation?
So good.
Nailing it. Number 5, Sapinia species, which likewise can lead to granulomatous amoebic encephalitis, but due to the fact that there is only 1 report of a human case in an immunocompromised patient, we doubt this is what the patient is suffering from. The differentiation between an infection with Acanthamoeba and Balamuthia is oftentimes only possible via PCR. Thank you for this great case. All the best, Michelle and Alexander from the First Vienna Parasitology Passion Club. That's great differential, Daniel, right?
That's fantastic. I was jealous. I'm like, this is the kind of differential you want on rounds, right? Can someone give a differential and go through like this? Fantastic.
You're next, Daniel.
All right. Christopher writes, Bom dia TWiP team. I am writing this from Brazil, where I am going to stay for a little less than a year to study HIV/AIDS in pregnancy. One of the projects I am going to start in the near future is toxoplasmosis in the setting of HIV/AIDS. Some of the outbreaks of toxo that have occurred here in Brazil have interesting stories, including one that is thought to have been driven by waterborne transmission. I am currently reading the online parasitism textbook to brush up on the subject, which helped me interpret the case findings for the 50-year-old man with encephalitis. It seems like this is a slam dunk case for toxo. However, I do not see any glaring risk factors that explain how the infection could proceed to encephalitis in someone who is relatively healthy. I wonder if there is something else going on, like a hematological disorder or malignancy that has yet to be discovered. Cheers from Christopher Hernandez, David Geffen School of Medicine at UCLA.
Natasha.
Fantastic. Hakan writes, hello from sunny Athens, Georgia. Currently a strong breeze on a sunny day, sitting around 77 degrees, one assumes Fahrenheit. For this week's guest, based on small, round organisms found in a human brain lesion, I gotta guess Toxoplasma or possibly Haemondia, given the ubiquity of the organism and the lack of distinct features in the morphological description. Treatment might include sulfadiazine, clindamycin, and or pyrimethamine, depending on the patient's tolerance of sulfa drugs. I hope you're well. Thank you for the episode and the fun case, Hakan.
Christina.
Anthony writes, hello all again. The symptoms in MRE are a dead giveaway for Balamuthia infection, but the size of cyst seems too big, as Balamuthia cysts are said to be only 20 microns in size and no bigger. Due to that, I think I will change my reply to some sort of brainworm, perhaps pork tapeworm or raccoon roundworm. Anthony.
All right, we have one from James. I won the book last month, so take me out of the running. It's quite an incredible autumn in Denver with clear blue skies, lows in the 40s, F 4 to 10 C, and highs near 80 F 27 C. Some years by this time we've already had snow. My garden is still producing tomatillos for my wife's killer green chili. I tell our medical students that climate change means every year in Colorado. So, on to the case. Man with no real history shows up with a temporal lobe mass lesion, granulomatous inflammation, and infectious forms, that's in quotes, about 50 microns with a central dark area. A nucleus, perhaps? In protozoa, of course, I'd think about Acanthamoeba, which causes granulomatous encephalitis and sometimes brain abscesses. Balamuthia can be similar, and Amoeba abscesses have been found in the brain. Toxo is a lot smaller, unless you count the cyst as the infectious form. Kind of weird for Naegleria, but the size and description of the organisms fits one of our amoebic cousins pretty well. In helminths, I always wonder about T. solium with cysticercosis, but I don't like the description much. Echinococcus is an interesting thought. The protoscolices might be about the right size. I guess I still favor one of the blobs, amoeba, and would really have trouble with which one, but I guess I'll go out on a limb and guess Acanthamoeba. James is at Rocky Vista University. All right, that does it, Daniel. What do you think?
All right. Well, we still have a few more guesses, don't we? 3 more guesses. And we'll start with you, Dixon. Dixon, you want to grab your microphone and what are you thinking?
Well,
what are you
the
thinking?
voice of ignorance is about to speak. I need more laboratory data for this to make a decision. I would love to know I would like to see the radiograms also to make a decision based on what I already know about the presence of, let's say, neurocysticercosis, which was my first impression, but it's not my guess. I'm not going to make a guess until I have more data.
So you have to. We're
You got it.
twisting
You got it. That's the game,
If
Dixon.
you want me to make a fool of
You're not-
myself
you're
in
not gonna
public,
win a
I'm willing to
book.
do that because I've done that many times. Okay, I'll pick Acanthamoeba.
Christina.
I'm probably going to make a fool of myself too. I'm going with James, actually, one of our writers, because he's thinking amoeba, but wasn't quite sure which one. I think that would be my guess. So I have a slide in my slide collection that very clearly looks like the sketchy description we have from this particular microorganism, but I cannot remember the label of it without looking back at my collection, which I do not have here. So I'm just going to go with amoeba and a, can't remember the name of it now. Someone wrote it, granulomatous amoebic encephalitis would be my guess, but I could be wrong.
Now, the fact that there's granulomas, does that make you think of a type of amoebic encephalitis, just sort of thinking?
Possibly Balamuthia, but
Okay.
do you know? I'm a bit sketchy on my amoebas.
Okay.
Give me a kinetoplastid any time.
All right. What about you there, Vincent?
Well, I'm leaning towards Balamuthia, but these multiple nuclei, I would have liked to have seen that in the report, right? But it just says round infectious forms, about 50 microns with some surrounding clearing and a dark area. So, it doesn't sound like multiple nuclei. So I'm a little uncertain, but I think everything else sounds to me like Balamuthia. My first thought was neurocysticercosis, but that's because every time there's a brain issue, I think of that or an amoeba. So I would just make a random guess. I would say Balamuthia, yeah.
So it sounds like you'd like to actually see the pathology and have a pathologist tell us what they see under that microscope.
Well, I would like to know how many nuclei there were instead of a dark form in the middle, right? So that would clinch it, I think, right?
All right. Well, Natasha, do you want to unveil the case?
Of course. So thank you all for your great guesses and those who wrote in. The diagnosis was confirmed via broad-range PCR and later by metagenomic next-generation sequencing to be Balamuthia mandrillaris granulomatous amoebic encephalitis, which is very hard to distinguish from Acanthamoeba. So I think really everyone got it.
Excellent. Excellent. All right. Well, before we talk a little bit more about the case, should we give away the book and then talk a little bit about how this patient did? So should we do the random number generator?
Yeah, let me
How many numbers do we have?
let me queue up. But I wanted to know, so you said it was next generation sequencing that confirmed it, right?
So it was initially diagnosed via the broad-range PCR, which is a PCR panel available at the University of Washington, which tests for Acanthamoeba and Balamuthia, and then subsequently confirmed by research-based metagenomic next-gen sequencing on the brain biopsy.
And how was the patient treated? Is it okay to ask that now?
Yeah, actually, I think that's important because that was a big part of this case. So in general, right, we have not great outcomes. So what did you guys do?
Yeah, so I will say I actually became involved in this case when it was time for the treatment. So let me say that the treatment of amoebic encephalitis, or blobs, as one of our write-ins delightfully called them, is a matter of significant discussion and not something we know how to do perfectly. The CDC currently recommends a 6-drug regimen to treat people with confirmed Balamuthia, which includes the following 6 drugs: pentamidine, miltefosine, sulfadiazine, flucytazine, fluconazole, and a macrolide, which is azithromycin or clarithromycin. So this gentleman, after conferring with the CDC, was started on all 6, and albendazole by the initial team, which is also sometimes used. But the trouble with this regimen is that, one, it doesn't work perfectly. Survival rates on people who are given any of the regimen is still only around 23%, and that's compared against an overall survival rate of this condition of 10%, which is an incredibly bad survival rate. It's worse than anything except for the related pathogen Naegleria and symptomatic rabies. And the other problem with this regimen is that it's got really significant toxicities, many of which our patient experienced. Pentamidine caused severe hypoglycemia and had to be stopped. Sulfadiazine caused renal calyx sloughing, leading to acute renal failure and had to be stopped. And flucytosine caused severe bone marrow suppression and had to be first stopped and then restarted at a much lower dose. So on the sort of 4.5 meds that we had him on, the brain lesions were beginning to increase. And at that point, we decided it was time to try something new. So I will tell you.
Which was?
See the dramatic pause.
Sorry. So at that point, I went through the literature, and I came up with a paper from a researcher who's actually at my institution, Dr. Joe DeRisi and his lab, led by the epic postdoc Matt Lowry, which essentially realized that because there were not great treatments for this disease, they set about doing a huge drug screen of 2,000 compounds against Balamuthia in the lab. And these compounds were either locally or internationally approved for use in humans. And remarkably, they actually only came up with one good contender, one compound that was both very amoebicidal and also was approved for systemic human use, not veterinary, not topical, something that could be given to people. And that was a drug called nitroxaline. I had never heard of nitroxaline. I don't think many people had. It's a quinolone. It's a pill. It's an antibiotic related to the things that we use to treat UTIs. It's available in Germany and several other European countries and China, mostly to treat UTIs. And I called up Joe, who was very responsive, and said, do you think this might work? And he said, I think it will. And then I set about trying to get it, which was its own adventure. It's tricky to get an emergency drug approval by the FDA, although they were fantastic and incredibly helpful. It is tricky to get a drug imported urgently from another country, which is what we had to do. But we did get the drug, we did give it to the patient, and then it worked. Now, we didn't stop any of his other meds, so I can't say for certain that it was the nitroxaline, but with addition of nitroxaline to his regimen, the lesions dramatically shrank, and by 7 weeks were detectable, but so much smaller that it looked like a different MRI. This patient is alive about 2 years post-presentation, and that is the subject of the case study that was published, to which one of our readers was alluding. And so since then, we've continued to work with different teams, and I'm happy to talk about what we're doing on trying to improve the treatment for Balamuthia and related amoebas.
So how much, you gave 7 weeks of treatment, was that daily?
Yes, nitroxaline is given as a pill. The dosing varies by renal function, but it's 2 or 3 times daily.
Okay, and so this could presumably be used for other Balamuthia infections in the future, right?
It could be.
Yeah.
In fact, it may be.
Okay.
I would say that without giving any details for cases that are not mine, we now have a second case for which a patient with Balamuthia mandrillaris has been treated with this drug and does appear to be doing better.
So, I mean, how many cases a year do we know of?
Yeah, that's a great question. So if you're talking about the United States, the number of patients diagnosed, my ballpark would be approximately once a month. And I would very briefly pause and say the CDC have fantastic experts on all things amoeba, and I frequently refer questions to their website. But in the States, for Balamuthia, it's about 1 a month. Yeah, for acanthamoeba, I think similar order of magnitude. And Naegleria, which is the third of this sort of dastardly trio of amoebic species that infect the brain, is very, very concentrated in the summer because of the epidemiological link with people diving into warm water and sort of forcing that water up their nose, typically young boys. So Naegleria is seasonal. Acanthamoeba and Balamuthia just sort of exist and occur throughout the year.
So Balamuthia is environmental. It's in water, and same risk factors as Naegleria, diving into water. Is that right?
No, frustratingly not. So Naegleria, we understand how you get it, which is you dive into water or you use nasal rinsing that puts water in your nose. If you do that, do it with distilled water. I will say that I have a horror of nasal rinsing personally after this work. But Balamuthia and Amoeba are environmental. They seem to live in the soil. And we really do not understand why some people get them. I spend a ton of time outside. I am constantly in contact with soil, as are many of us. And yet these cases are amazingly rare. So I'd say that, like many things, we just don't understand why some people get this illness.
Natasha, can I ask you about the patient? So you said he's 2 years after, he's okay, but does he have any sequelae from his infection? So any negative effects?
I think that's a great question. I will say I'm not going to reveal anything about this patient that's not in the published paper. So I'll just say that he is living in the community and is generally doing well.
Thank you.
So maybe one of the risk factors is gardening, right? Because you're moving soil around, outdoor gardening. So maybe you could ask in the future the patients, hey, you do any gardening, right? Does that make sense?
Well, we definitely know it's in the soil, right?
Yeah.
I was involved in the case in Peru where they actually, did the matching. Like this young lady had Balamuthia. They actually went to where she lived, this village, and they actually were able to detect Balamuthia there. So we do think it's soil, but why is it only one a month? Like, there's probably something about the host that makes them more susceptible because it isn't an obvious, exposure.
It's probably unlikely that mandrills do a lot of gardening, just to bring that up.
They don't, but they're
to unpack
near
that a
dirt.
little, the first case ever reported was in a female mandrill at the San Diego Zoo, hence the mandrillaris. I assume that they do not garden, but a lot of people have this disease and have no obvious risk factors. And similarly, a great many people garden. I do, of course, unsuccessfully, and yet, clearly, this is not the only factor that must exist. There are much more gardeners than amoeba-infected people. Thank goodness.
Okay,
so
you don't like
you
my
can
idea.
keep gardening. It's okay.
Yes, I do not recommend gardening.
We're going to
so-
get hate mail. They were saying bad things about gardening, Vincent. So
No, it's not
we
bad,
just want
it's
to
just-
make it really clear gardening.
I'm just thinking of, you talk to a patient, you ask them where they've been, what they do, and that could be part of it. I know that not every gardener gets it, but with infectious diseases, not everyone who has a risk factor gets them typically.
Yeah,
right?
we had some interesting epidemiology on Long Island with tick-borne diseases
Yeah.
where during the shutdown they couldn't do what they normally did. So I remember one woman distinctly with a really severe case of babesiosis.
Yeah.
And she said, I was really bored. I couldn't go to work, so I picked up gardening, and I was spending all this time outdoors. And
See? A lot of people garden. Not everybody gets tick bites, right?
There's also
true.
a ton of little kids out there that gets into the dirt all day long without any effect whatsoever. Is there an age group that this is specifically aimed at?
No, somewhat, again, frustratingly. Balamuthia affects people from the extremes of age. If you look at a CDC paper, it's Cope et al., which I have gone through many times, the youngest person reported was 0.33 years of age, and the oldest was 91.
I'll be darned.
So it really affects immunocompromised, it affects immunocompetent, it affects the young, the old. It has a slight male predominance, but I don't think we understand why it happens.
Daniel, I'm sorry, Natasha, was this the first Balamuthia you've seen?
Oh, certainly.
Yeah, because you're very young, I know. Daniel, you're not so young.
I've seen many cases,
Yeah, Dixon,
unfortunately.
did you see them when you were working?
This was a newly discovered organism by the time I had retired. So everything is popping up all over the world at rates that we don't have a good grasp on, but encroachment into intact ecosystems has a way of bringing out certain infections. This isn't one of those, though, I don't think. The global distribution for this parasite is where?
Is everywhere.
Everywhere.
It is worldwide. There are the most cases reported in Peru, China, and the United States, as far as I can tell. I have never heard a good explanation as to why. Another thing that I would say is that our diagnostics are getting better. This is a very, very hard diagnosis to make because most tests will not reveal it. And so one of the very, very strong use cases for metagenomic next-generation sequencing, which is something that I do a lot of research with, is to detect pathogens that cannot be readily detected in any other way. And pathogens that most clinicians, including my young self in 2021, have never heard of and therefore won't recognize.
Can you just repeat the effect of the use of the antibiotic that was discovered on the patient's health? Did it cause any side effects at all, or was it totally well tolerated?
So the antibiotic that we added, called nitroxaline, is certainly, I would say, has a more benign safety profile than the 6 drugs that were sort of in the initial treatment. Pentamidine, sulfadiazine, flucytazine are particularly toxic. Fortunately, for us and for the future use of nitroxaline, it's been very well studied after being used for a UTI treatment for so long. The usual side effects are nausea, and it can't be used in people with very low kidney function, but I would say that I don't think there was a massive problem with it once we'd started it.
So the patient's symptoms, disorientation, inattention, aphasia, they all went away eventually?
Largely improved. Some of them may have been post-ictal when he first came in after that seizure, so that's his initial exam. And then again, I think I'll stick to what was in the paper and say that most of his symptoms had improved.
Okay. Now, I also want to know the CSF. I don't know what these mean, and maybe some listeners don't, so maybe you can explain which of these numbers relate to the presence of Balamuthia. So you said CSF, increased nucleated cells, lymphocytes, neutrophils, monocytes, protein concentration, and glucose. So how do those relate to the infection?
Yeah, so basically when you're looking at cerebrospinal fluid as an infectious disease clinician, you're looking for a couple of things. I typically want to know, is this consistent with a bacterial meningitis? Mm-hmm. Or is it consistent with something else? And then I'll talk about the bucket of something else. A bacterial meningitis is typically, classically, going to have high nucleated white blood cell counts with a neutrophilic predominance. It's going to have a high protein because it has a lot of bugs in it, and it's going to have a low glucose, presumably, or sort of classically, because the bugs are eating the glucose. And that puts me on the sort of path to a bacterial meningitis. Bacterial meningitis, highly deadly, fortunately quite rare. Does not come up actually that often in clinical practice, thank goodness, although we think about it all the time. What this patient had was more of a mixed picture. He had an elevated white count, but it was lymphocytes, which are a different kind of blood cell, and his protein was not appreciably high, nor his glucose. His protein was somewhat high, but not sky high, and his glucose was normal. And that puts me into the bucket of there is something going on in the viral, fungal, other encompassing parasites in the vast focus of this show, or autoimmune buckets. So when I see that kind of profile, my antennae perk up, and I sort of have to think about it a little bit more.
Okay. So, go ahead, Ditson.
I had another question about its predilection for the central nervous system. Has it been found anywhere else in the body?
Oh, yes. Like so many things that it doesn't just do one thing. In different areas, especially Peru, it actually usually presents as a skin lesion. Less so in the States, for reasons that I do not understand. It can show up as a pneumonia. It can be systemic and disseminated, especially in immunocompromised patients, and it can present as sort of focal lesions elsewhere. It does a lot of things.
Did we not have a case, Daniel, that presented a bit like that in the distant past?
You know,
A
the
little
the
girl
case
in
that I
Peru?
talked a little bit about, the one in Peru where they went back to the village, it was actually started off as mainly as a skin lesion, then also had CNS involvement. So I think that's interesting. A lot of times when we see something in CNS, we get really focused on that, but that may be just one of the many places the organism can go.
So the skin lesion is the initial source of the infection, I presume.
Maybe, in some cases.
Okay, maybe.
Yeah, we had a previous case at UCSF that was also published and kind of kicked off the basic research that identified this drug, where it started as endophthalmitis, so a focal infection of the eye. I think the only thing that I believe with some degree of certainty is that wherever it starts in the body, it has a predilection to end up in the CNS, which is where it's most fatal.
I just had a random thought that perhaps the difference between the patients who become infected and the people who don't become infected after the lesion disappears might be a skin immune system problem. Maybe dendritic cells and antigen processing, something like that. You know, you're reaching for straws when are there animal models for this now available?
Not good ones. Basically, I have since this case learned a great deal about the.
Besides mandrills, by the way.
Yes, I've learned a great deal about the diagnosis and treatment of amoebas, and amoebic infections have been reported in a remarkably wide variety of wildlife, including mandrills, dogs. If I recall correctly, I think bears. But we don't have a great. There are some labs that work with animal models. Not many, and none that I'm aware of that do Balamuthia. What we do have is a fantastic in vitro model where we work with Balamuthia in the lab. I have an incredibly talented postdoc who I work with, Katie Marquise, who's really done some groundbreaking work with Balamuthia in the lab since we had this experience and published this first paper.
Did you look anywhere else in this patient for Balamuthia besides the brain? Did you look in the blood or any other tissues?
Blood cultures were negative, and there was no evidence of disseminated disease.
And monitoring their immune responses, did you notice any tick and upgrade for, let's say, IgG or IgM antibodies associated with the infection? You might be able to use as an indicator of the infection before you actually had to biopsy the lesion.
It's an interesting question. I would say that this is a hard diagnosis to make in general, and often requires either positive CSF or a biopsy of the lesion, as it did in our case. And I think what tends to separate, I don't actually fully know what separates that, is the answer. Like many things, much to learn. But for some patients, CSF testing and CSF metagenomics or CSF PCR will be positive. In some, it requires a brain biopsy to make that diagnosis. And this is a diagnosis where you do want to be somewhat sure, because the treatment is non-trivial. I would argue that the greater use of metagenomic next-gen sequencing, which allows you to detect pathogens that maybe you have not thought of, is likely to keep increasing the diagnosis of cases, and hopefully, by sooner diagnosis, the survival.
One final question, please, before we go off the air. The initial lesion is usually a skin lesion. Is there a scar that's left because of that, or some remnant evidence that this patient has experienced Balamuthia as a gardener or whatever? If a thorough look throughout the...
I would say in the cases I've seen, there's been scarring left behind, usually a significant amount of time. But I also want to plug for the metagenomics. I mean, you know, in medicine, we always had this idea that, you know, we take this incredibly detailed history, like, you know, diarrhea as an example. Is it watery? Is it bloody? This and that. And then the whole idea is we now know the diagnosis from the history and we confirm it. But I think as we get these sort of call them syndromic panels, syndromic testing platforms, we're starting to realize that maybe we weren't quite as smart as we once were, and that maybe more of what we were taught is not really true, and maybe things do present in different ways. So the idea of going in and saying, there's a CNS infection, not sure what it is, kind of need to know what it is, and then the metagenomics telling us what it is. I think of it as a huge advance. I don't think of it as backwards. You know, if we can move forward and more quickly make a diagnosis, more quickly help our patients, I think that's exciting future.
Yeah, can I use a metaphor? The metaphor I might use is the game Go Fish. So a lot of the tests that we have are us playing Go Fish and saying, do you have a purple striped fish? And the test may say, no, we don't. But what we actually want to know as infectious disease doctors is, do you have any fish? And what fish do you have? And we would like you to include fish, please, that I have never heard of, or maybe in this age of zoonotic spillovers, fish that nobody has ever heard of. And that is what the test, in theory, can do. It's the only test that doesn't require you to predetermine the kind of fish.
No, and I think with the last pandemic, this is a great lesson. I mean, we went into that, and I remember, if you did not know what the pathogen was, if you did not order that specific test, you didn't get it. So if you had the ability to say, oh, my patient has a respiratory illness, let me order a panel, and it will tell me what that is. I don't have to know ahead of time. We would have known quite a bit sooner. We wouldn't even need to engineer a specific COVID test. We would have just done the test that tells us what the person has. So instead of go fish, you just say, can you just turn your cards and let me see?
So I have another game to add to your game, though. So you go fish first. You know there's a fish, but where is the fish? So the other game is where's Waldo?
Yep.
And I used to give a lecture to the pathology group at Columbia when I was still there. And I used to tell them, I call my lecture, Where's Waldo? And it was played by throwing up a slide on the screen, a histological section, and somewhere in that section there's a parasite. Can you find it? And they were very good at finding those parasites, very good. They found Waldo almost every time.
So, Natasha, would you say this is one of your more interesting cases that you've ever seen?
Oh, yes. I mean, interesting in a lot of different ways. Interesting diagnostically, although I was not the one who made the diagnosis, but also interestingly in what it's taught me about how new therapies are developed, discovered, used. I have worked with extraordinary people because of this case in a number of agencies who I am extremely proud to call colleagues. And I think it's been a real turning point in my career. I have learned so much.
Pretty unusual to have a new drug available, right? The screen had been done before you had this case, correct?
Yes, and the screen had been done because of another case.
Okay. All right. Anything else, folks?
Well, should we learn a little bit about Natasha's
Well, I want to give away a
history?
book first.
Okay, book first.
And then we'll learn about Natasha, yeah. I need a drum roll. We had six
We're ready.
eligible guesses.
Ready?
I'm ready. Number one, very first guess, which is, I'm scrolling upwards, Rafid from rural Quebec. So Rafid, you get yourself a hypothetical textbook.
And we should remind you don't have to get it right. You just have
No,
to try. This
just
is
have to
this
try.
is like participation.
Actually, Rafid's
Trying
guess
is everything.
Rafid's guess was amoebic granulomatous encephalitis. That's good, right?
That's it.
Oh,
Yeah.
we'll count it. We'll absolutely count it.
Anyway, Rafid, send us your address and phone to TWiP@microbe.tv. All right, Natasha, tell us all about yourself, going as far back as you remember.
This is
Not
infectious
everything, but
disease. So
obviously,
where were you born?
where were you born? Where you went to college, medical school, all that, fellowships, and then we're going to ask you about what you're doing now. So.
Oh my goodness. 33-year-old woman with a past medical history of infectious disease doctoring. I was born in LA, grew up, went to college in LA, and then did my PhD at the University of Oxford, and then half the University of Oxford and half the National Institutes of Health. After that, I decided that I would like to be a doctor as well as a scientist. So then I went to school at Columbia Medical Center, or the Vagelos College of Physicians and Surgeons, where I met Daniel Griffin as one of my attendings during my third year rotation. And then I went on to residency and now
But you
fellow.
I also taught you, apparently, right?
Oh yes, I'm sorry. And Vincent wasn't.
You forgot. It's okay.
During which time Vincent Racaniello taught one of my preclinical classes, and I also, another fantastic person at this conference, Christina Coyle, also taught me, and I remember the shimmering enthusiasm for parasites, viruses that sort of pervaded both of their lectures. And while I was at Columbia, I participated in a particularly idiosyncratic project with Daniel that I'd love to talk about. And then I went on to do my residency and fellowship at UCSF.
So why did you do science in the first place? You decided to get a PhD. How early in your career did you know that's what you wanted to do, and what was the source of that interest?
Oh gosh. Well, I knew I wanted to do something that involved human health, and I wasn't certain if medicine was for me. And also, I did apply to MD PhD programs, and the first time round didn't get into many, or I think one, but not many of them. But I did get accepted by a PhD program, so I thought I'll do this, and then I'll see afterwards if I still really feel drawn to medicine. Plus, I was very lucky in my mentors and advisors. I had some fabulous people who I worked with at Oxford, at the NIH, and just real people it's been a joy to continue learning from.
What did you work on for your PhD?
So I worked on the role of iron metabolism, and specifically the hormone hepcidin, in which controls iron. And iron is sort of the equivalent of crude oil in global geopolitics. A lot of wars get
That's
fought
good.
over it. Basically, I looked at the regulation of the human iron hormone hepcidin during malaria infection specifically.
Yeah, the battle for iron is for microbes. They want iron, right?
They need iron,
Big
and we
deal.
want to lock it up.
So they want to steal it, and we try and sequester it, and they get around that. It's really interesting stories, right? Right.
Yeah.
And if you throw iron into the oceans, it causes blooms,
It certainly does.
right? So if you have rusting things that you're dragging behind
It's the
ships-
limiting factor in the ecosystems of the world, primarily, is iron.
Yeah. So if you look
And
at
phosphorus.
if you look at your web page, it's got Balamuthia right there. We could have guessed. I didn't look at that, by the way, but there's something else here I wanted to ask you about. So you're a physician at UCSF, infectious disease physician, right?
That's right. I'm in the Division of Infectious Diseases.
So you have here on your CV avian malaria. Tell us about that.
Oh my goodness, that was so fun. When I was a medical student, I heard that Harvard had a program where their medical students could rotate at the zoo. And I thought this sounded amazing. I've always had a huge interest in animal to human outbreaks. And so I thought, I've got to do this. So I went to the zoo to a veterinarian there who's amazing called Dr. Bartlett. And I said, I'd really love to rotate with you. And she said, well, potentially, but we need you to be able to contribute something that we don't have the time or the expertise to do. So I said, well, I know a lot about malaria. And she said, well, fantastic, we have a malaria problem. But first, before I could get into this malaria problem, I needed a faculty advisor from Columbia who would agree to sort of supervise me on this project and generally lend it a much needed air of credibility. And the only person I could think of to go to was my attending, Dr. Daniel Griffin, who not only agreed to supervise me on this project, but also provided key input in the manuscript. Luckily, he did become my supervisor. Columbia did approve it, and I spent a completely delightful month learning from the zoo veterinarians of the Bronx Zoo, studying alongside them, and also trying to understand better avian malaria in their penguins.
And they're penguins.
Penguins, eiders, and terns.
Right. So, Dan, what's the relationship between the case that we did and that?
Yes, so that was the problem, is they were having the issues where you have birds that evolve in areas without mosquitoes,
Right.
and then you bring them to an area like the Bronx, New York, they get bitten by the local mosquitoes, which actually have avian malaria, and then they would actually get sick, they would die, and one of the challenges, often by the time they recognize it and want to treat them, they're already too sick. So the whole idea was, can you identify, maybe it's a certain type of avian malaria that's killing them, that's the more virulent form. And Natasha's work led to that identification.
It should also be mentioned that the Nobel Prize for medicine in 1905 was given to Sir Ronald Ross for discovering that mosquitoes transmit malaria to animals, in this case birds. He worked on canaries in India.
So
So
the case we did on TWiP, that was one of them that you were working on. Is that correct? Or it was just not?
I don't know if the case that you presented was one of the particular penguins that I got to work on the data of.
Okay.
I'd like to think it was.
But there are multiple such cases in penguins, not just one, right?
Oh, no, not just one.
Yeah.
Penguins, terns, and eiders. And I really worked more on the banked data than on the penguins. But it was still an absolutely delightful project.
Yeah, we had Paul Calley come to Columbia to present the case as if it were a young child.
I know.
And with a diet of fish, I think, and that should have been a red herring, right? Oh, a red herring, Dixon.
Oh, my goodness.
Eating fish primarily. So and then we went to the Bronx Zoo for the reveal.
I would like you to know that I restrained myself from saying that Daniel had taken me under his wing.
That's great. I love it. Very good. The one thing I remember from that, Daniel and Dixon and I went to the Bronx Zoo very early one day to meet with Paul. So we get out of the taxi and we're at the gates, and these guys say, we need to have breakfast. So they disappear into a local place for like 30 minutes getting eggs on a hard roll. Oh my gosh, Dixon. We're there to do a podcast.
You need your stamina when you're busy all day long with a patient.
But that was a great case. I wanted to ask you, so obviously you were affected by COVID, right? And you had to change everything that you were doing. But before that and since, what are the most important infectious diseases that you see in San Francisco, for example?
Wow, the most important infectious diseases, it's hard to choose one. So I would say in 2019, when I had just joined UCSF, I decided to change my focus from malaria, which is where I'd been, to looking at respiratory pathogens. And I started working with my mentor, who's still very much my main mentor, Chaz Langelier, and also his collaborators, Dr. Carolyn Calfee and Joe DeRisi, who are my mentorship team. So I was working on that as of 2019 in a limited way as a resident. And then obviously it was 2020. And like everywhere else, we were very much affected by COVID. And I would say, at the time I was mostly just a resident working in the ER and the ICU and the floors and trying to do the best that we could. And that was also incredibly meaningful. But since then, I've continued to work on the use of metagenomic sequencing to diagnose, identify treatments, and prognose people who are very, very sick, critically ill from either lower respiratory tract infection or sepsis. And that's sort of my main project. But the amoebic encephalitis project is also a major focus and something that I work on.
Do you see a lot of RSV this year?
Not as much as my pediatric colleagues.
Okay. Right. I asked a guy I met at ID Week the same question. He was from San Antonio. I said, what's an infection that you see often? And he said murine typhus, which you wouldn't get in San Francisco, right?
What? No, I've not diagnosed murine typhus. I have invoked it once, but I was wrong.
Invoked it. That's good.
But I think that one of the things that's most interesting is sort of, can we identify in our sickest patients usually, what is causing their infections, and can we do so fast enough to treat them better,
right,
and also to identify new things that are coming or changing or increasing. I mean, for example, I have been a doctor for 5 years? It's a very short time. And we've seen the emergence of not only COVID-19, but also Mpox, but also Candida auris, and also a whole host of other things. So I'm hoping that we can get a better network.
Yeah. Any other questions? Dixon, you good?
Millions of questions. No, we'd have to talk later because we've exhausted the official questioning, but I have lots of personal questions to ask you about your career.
All right.
And how you see yourself 10 years from now.
Oh gosh, 10 years from now, I'm working on it, and I will say that that's in process. We're trying to figure out how much research versus how much medicine. I derive great meaning from both and from taking care of patients. I would say I'm currently in the process of figuring out my next job, so I'll not say too much. But I hope that it's something where I can continue to treat patients, continue to make contributions to the greater field of research, and of course continue mountaineering and alpine skiing with my partner and friends.
All right. Okay. Daniel, do we have another case?
We do. Imagine that. We actually have a lot of cases. We have like a list, a backlog now. So we'll start with a case, and this is a case that
This is one of yours, right?
this is one of mine.
Okay.
This is one of mine. And so here we have a woman in her 50s. And just to give you a little bit of a backstory, this woman is living in Haiti, which, as we all know, is not the best situation at the moment. Her daughter is one of the nurses at an academic center at which I'm connected. And so the daughter actually somehow arranges for her mom to come to New York. The mom is incredibly ill, though, so ends up basically straight to the emergency room. Woman is in her 50s, has HIV. She's not been compliant with medications. She is having trouble eating. She's been coughing for days. There's vomiting. There's oral thrush. You can see it all inside the palate, all the way back, actually very concerning on history for, the candidiasis in the esophagus. The big thing, she's had this incredible amount of non-resolving voluminous diarrhea. So she's admitted for this failure to thrive, deconditioning. She is found to have parainfluenza 3 on her RVP, respiratory viral panel, respiratory pathogen panel, we call them at this academic center, which is appropriate because not just viruses anymore. She's undergoing a tuberculosis rule out. She's very dehydrated. She's had significant weight loss and lethargy, really accelerated over the past few weeks. And that diarrhea that we're talking about is really an acute on top of everything else. The only past medical history we have is the HIV positivity. She has been living in Haiti. She actually remarried, but her last sexual encounter was 2 years ago. No illicit drug use. She does occasionally drink alcohol. She's not allergic to anything. We have, relatively unremarkable vitals. She's afebrile, pulses in the 70s. Sort of remarkable considering how cachectic and dehydrated she is. Breathing about 18. She's 5'7". She weighs in at 54 kilograms. And generally, she's thin, cachectic, subdued, and we get some lab work as well. We have a white count of 5.2, which is in the normal range. She is anemic with a hemoglobin of 8.7. Platelets, 818, so very elevated platelets. She, on her differential of her white counts, actually fairly unremarkable except for an elevation of the monocytes. We get some lab work on her. Initially, the sodium is just a little outside of normal, 136. Creatinine is elevated. CD4 count is in the 50s, elevated viral loads. And the big thing that we're going to try to work on here is what is this voluminous diarrhea, because we're going to find a parasitic etiology for that.
So obviously she's not being treated for HIV, right? With that kind of CD4 count.
So so her CD4 count is down in the 50s. So normally would be up around 800 or so.
So she's not getting antiretrovirals.
So she has been off antiretrovirals. Okay. Yeah.
All right.
Any other questions for me?
What kind of living situation are we in?
So she actually was in the city. She was in, yeah.
She lives in the city, so she's eating at home. She's eating at restaurants. There's no rural.
Not a lot of eating at restaurants. Just
at home.
pretty impoverished, making food in the house, having family supply food.
And has not traveled recently except for coming to New York, obviously.
No, she's been in Haiti. She's been in that place, and then, just direct to New York.
Do they have any pets?
No pets. There's animals in the area, but she herself is not a pet owner.
So it's her and her partner in the house, and that's it?
No, well, it's a sort of a multi-generational family, so there's lots of family there.
And everybody else is okay?
Yep, it's just her.
Any questions?
And that's actually good. That's a good question.
You taught me a little bit, Daniel.
Yeah.
Did you start her on antiretrovirals straight away? And
so we did.
did we see an improvement?
We're not going to get there yet. We've still got to get a diagnosis, but that's a good question.
All right.
Well, no, it's a good question because part of the question is it something that just fixing the immune system can get us on top of, or is there something that will require treatment?
So you want to know what is causing the diarrhea?
What is the cause of this voluminous diarrhea in a woman with AIDS from Asia?
How long has this been ongoing, the diarrhea?
It's been for weeks.
Weeks.
Weeks, yep.
Yeah, well, I mean, lots of ideas occur to me that...
Don't tell us what it is, but any more questions?
A microscopic examination would tell us a lot more.
Yeah, well,
but we can't go there yet because that's obviously
Okay.
part of the answer.
All right.
But,
Natasha, did you have any questions for us?
How long has she been in New York? When did she leave Haiti?
She basically came to the airport and straight to the academic center.
Thank you. That was
Hours.
that was my main question.
Yep.
Okay. That's
All
it for
right.
me. That's you can send your guesses to TWiP@microbe.tv. Okay. And Natasha, you could send a guess too.
I will. Thank you so much for having me.
We'd love to have that. You can find the show
pleasure.
notes at microbe.tv/TWiP. If you like what we do, teaching science to everyone, please support our work. We do this for free, essentially. We are nonprofit corporations, Parasites Without Borders and Microbe TV, and we need your help to be able to continue to do this. So you can go to microbe.tv/contribute for various ways that you can help us. And of course, if you're in the U.S., your contributions are federal U.S. tax deductible. Daniel Griffin, Columbia University Irving Medical Center, parasiteswithoutborders.com. Good to see you here in Chicago, Daniel.
Oh, thank you. Good to see everyone.
Dixon DesPommiers at Racaniello.org and thelivingriver.org. Thank you, Dixon.
You're very welcome, Vincent. This was great.
Christina Nowles at the University of Glasgow. Thanks, Christina.
Thanks, you. It was fantastic to actually see everybody in person for once. Usually we kind of are an ocean apart, so it's really
Yeah.
lovely to be here together.
Our guest, Natasha Spottiswoode from the University of California, San Francisco. Thank you so much for joining us.
Thank you so much.
I'm Vincent Racaniello. You can find me at microbe.tv. I'd like to thank the American Society for Microbiology for their support of TWiP and Ronald Jenkins for the music. Now, Natasha, you have the honor of signing off. So you probably know I get to a certain point, and you just have to say another TWiP is parasitic when I finish, okay? What's that?
He's going to cue you, and you're going to say another.
Oh, I see. Okay.
I'm going to say the goodbye part, the outro, and then
I
you're
got
going to
you.
chime in, right, with a nice, excited, not like Dixon who's half asleep all the... No, sorry, Dixon. Are you okay? You've been listening to This Week in Parasitism. Thanks for joining us. We'll be back soon.
Another TWiP is parasitic.
Yay!
Thank you.